Good morning, students. I'm Dr. Sadhna Devi, Assistant Professor, OBG Slims. So today I'll be dealing with one of the most important topic of postmenopausal bleeding, and I'll be speaking in depth about endometrial carcinoma. So without wasting much time, let's directly go into the topic. Okay, so coming on to endometrial carcinoma, we all knew that it is the third most common genital tract carcinoma. Okay, so coming to the age standardized incidence rate is 2.3 per 1 lakh women with a mean age of 60 years old. Okay, and the estimated new cases in India in 2018 is 13328 with 5,000, approximately 5,000 deaths. And when you see this hereditary carcinoma, one of the most one of the most classical example is HNPCC, hereditary non-polyposis colorectal carcinoma. So otherwise called as your Lynch syndrome. So it occurs at a much younger age of 35 to 40 years. So only for all the hereditary endometrial cancer, we advise early screening by 30-35 years. So that I'll speak later in the upcoming slides. So, okay, let's see. First, you should know what is the definition of postmenopausal bleeding. So, postmenopausal bleeding is any vaginal or any genital bleeding, any bleeding from the genital tract in a postmenopausal women, which occurring after 12 months of amenorrhea. Okay. So in other words, what to say? In a postmenopausal woman, after 12 months of amenorrhea, when they complains of any bleeding, that is called postmenopausal bleeding. But even the definition says 12 months of amenorrhea, you have to evaluate all the cases of postmenopausal bleeding after 6 months of amenorrhea itself. Okay. So we will go to the common causes of postmenopausal bleeding. So here, if you see, the most common causes atrophic endometritis and exogenous estrogen. So the atrophic endometritis contributes to 30% of the causes, and the exogenous estrogen also 30%. So other causes like the endometrial or the endocervical polyps contributes to 10%. And if you see the endometrial hyperplasia, it is 5 to 10%. Endometrial carcinoma, another 10% contribution. And cervical carcinoma is also, remember, not all cases of postmenopausal bleeding, you don't think in terms of endometrial carcinoma, you have to think in terms of cervical carcinoma also. So the cervical carcinoma is also most common genital tract cancer. Okay. So cervical carcinoma, uterine sarcoma, urethral caruncle also contributes to another 10%. Okay. So how will you evaluate a case of postmenopausal bleeding? So this is a common question in exams also. In Viva, they will ask you. We'll see. First, from the history taking itself. The history taking is very important. So in that, the risk factors, in the history taking, you have to ask for the risk factor, the familial history, and the past history. Like familial history, you have to ask for any family history of HNPCC like that. And all the risk factor I'll be again saying in my subsequent slide. Okay, examination. Examination includes per abdominal examination, per speculum, per vaginal, and per rectal examination. In that, in PV and PR, in PV examination, you have to check for uterine size, mobility, cervical involvement, parametrial involvement, lateral pelvic wall, or any bladder or rectal involvement. Okay. So the parametrial involvement, lateral pelvic wall involvement, and all is well felt in per rectal examination. Then you have to take her pap smear. Then USG. In ultrasound, you have to check for the uterine size. So the next modality of the investigation will definitely be a basic transvaginal ultrasound. In that you check for the uterine size, endometrial thickness, endomyometrial interface, myometrial ecotexture, and you have to assess the adnexus also. Saline infusion sonography can be used, and endometrial. So if any patient in TBS the endometrial thickness in a postmenopausal woman is 4 millimeter, she definitely needs endometrial sampling. Okay, that is the cutoff, ACOG cutoff of 4 millimeter in a postmenopausal woman. So how will you take the biopsy? Okay. So how will you take the biopsy? First thing you have to take is pipple endometrial aspiration. Okay. So that is a very common procedure we are doing. It is an office procedure. The advantage is that you don't require any anesthesia, and the postmenopausal detection rate of endometrial carcinoma is high. It is, the sensitivity is 99.6%. It is very high. Nowadays, we don't do dilatation curettage or fractional curettage, but we do this only when the pipple endometrial aspiration is inconclusive, or in case of cervical stenosis, yes, we do fractional curettage. Then the most specific and the investigations of choice will be hysteroscopic, the gold standard. So what we'll see, what are the hysteroscopic indication? The abnormal findings in transvaginal ultrasound with negative biopsy. Then inaccessible uterine cavity and persisting symptoms. Suppose the patient is always complaining of having this postmenopausal bleeding, but your pipple aspiration is negative, and and there is focal endometrial polyp. Suppose in TVS or SIS, if you find that there is a focal endometrial polyp, then again you have to do hysteroscopic biopsy. So we will see what are the contraindication of endometrial sampling. The first thing is acute pelvic infection. Any pelvic infection, of course, you should not do. You have to treat the infection and then only you have to proceed. And other things are bleeding disorder, pregnancy is absolute contraindication, and cervical carcinoma. Cervical carcinoma is a relative contraindication. We'll see pre-op evaluation for this biopsy. So the pre-operatively check her blood pressure, BMI, thyroid status, respiratory and cardiovascular system. You have to do investigations of CBC, RBS, screening for HIV, HBS, AG and TSH, and medical comorbidities should be optimized. Suppose the patient is a case of uncontrolled diabetes mellitus, it has to be optimized. Okay. And the procedure under short GA or sedation. The procedure can be done under preferably IV sedation or even with the paracervical block. The endocervical, you have to take the endocervical curating first. And then you have to introduce the uterine sound and followed by endometrial curetings. Okay. So this is another very important part. You should know the risk factors of CA endometrium. So the most common thing we all know is prolonged unopposed estrogen. When you see prolonged, which condition you are thinking? Yeah, it is anovulation and PCOS. So the prolonged unopposed estrogen, the relative risk you see is 2 to 10%. And HRT, hormonal replacement therapy without progesterone. So that is very, very risky, 4 to 8 times. But nowadays, no one does this. And another thing is, which I earlier told, it is anovulation and polycystic ovarian disease increases the risk to 3 times. Okay. And nulliparous. Nulliparous women, same thing, unopposed estrogen, prolonged unopposed estrogen. Again, the risk is twice or thrice. So, you see early menarche, late menopause. Suppose late menopause after 50 to 55 years. So there is again risk for endometrial carcinoma. It is twice or thrice. And obesity. So obese women, like see the BMI more than 30 kilogram per meter square. So another risk factor with low physical activity or physical inactivity is increasing the risk 2 to 3 times. Diabetes, hypertension, prior radiotherapy. Like patient has taken radiotherapy for some other malignancy, the risk increases to 8 times. And the familial history of uterine malignancy, the classic example is hereditary non-polyposis colorectal carcinoma or your Lynch 2 syndrome. It increases the lifetime risk of 50%. So we saw the risk factor. Now we will see the protective factors of and the screening protocol. Okay. Combined oral contraceptive pills increases the 50% protection, even up to 10 to 20 years. Okay. Even up to 10 to 20 years. So good physical activity. This thing we all know, physical activity control obesity. And when you see the screening protocol, there is no screening for there is no population based screening. Okay, only the patient with like there is a family history of HMPCC, you can screen the patient. Otherwise, there is no role for population based screening. And you have to avoid the condition which increases the unopposed estrogen. Okay. And the routine surveillance of asymptomatic women with PCOS, diabetes, infertility, and menopause, late menopause is not recommended. Okay. Is this point clear? So, routine surveillance for PCOS women is not recommended. Screening in women with family history and carriers of HNPCC associated with genetic mutation. Only you will screen these kind of patients. So, I want to talk about this screening protocol in HNPCC or your Lynch 2 syndrome. So, you see, Lynch 2 syndrome is a germline mutation of DNA mismatch repair genes. So you have to start screening. Screening for endometrial. See, the patient is having high risk for two carcinoma. One is the CA colon and another is the CA endometrium. So you have to start the screening for CA endometrium at 35 years. You have to take annual endometrial biopsy, history taking, and transvaginal ultrasound. Okay. And after 40 years, when she has completed her family, you have to perform risk-reducing hysterectomy with bilateral salpingo-oophorectomy. In case of screening for this colorectal carcinoma, you have to screen 5 years before the incidence of colorectal carcinoma in their family. Okay. And the screening include, yes, which this I have just now I have told, the annual screening with gynae examination, transvaginal ultrasound, aspiration biopsy starting from 35 years onwards. And at 40 years, hysterectomy, you have to perform. This is called as risk-reducing hysterectomy with bilateral salpingo-oophorectomy. Coming to this topic of endometrial hyperplasia, we know endometrial hyperplasia is abnormal thickening of the endometrium due to unopposed estrogenic action. So the WHO 2014, they have divided. Initially, we have this endometrial hyperplasia without simple hyperplasia, complex hyperplasia, those kind of classification. Now, after this 2014, we have only two types, the endometrial hyperplasia without atypia and endometrial hyperplasia with atypia or EIN, endometrial intraepithelial neoplasia. So when you take endometrial hyperplasia without atypia, there is only 4.3% progression to endometrial carcinoma. Whereas in EIN or AH, endometrial hyperplasia atypical, there is 28% progression. And concurrent endometrial carcinoma is found in 43% of cases. So timely detection and treatment will prevent endometrial carcinoma. Hysterectomy in endometrial hyperplasia without atypia. So hysterectomy is indicated when the fertility is not preferred in the following situation, which cases in a postmenopausal women or endometrial. Normally for endometrial hyperplasia without atypia, we give progesterone or LNG-IUS is a very good option. So we are seeing the option of hysterectomy is indicated only in these following group of patients. First thing is the postmenopausal women. Progression to atypical hyperplasia on follow-up. And even after you're giving 12 months of progesterone therapy and there is no histological regression, then also you have to perform hysterectomy. Relapse of endometrial hyperplasia. This endometrial hyperplasia is without atypia after completing the progesterone treatment and persistence of leading symptoms, and the patient who declines follow-up or endometrial surveillance, perform hysterectomy. So in this case, you cannot perform endometrial ablation. Okay. So endometrial hyperplasia with atypia. The postmenopausal women with, suppose a postmenopausal women, they have taken a biopsy and it shows endometrial hyperplasia with atypia, perform hysterectomy with bilateral salpingo-oophorectomy. But um, but the problem arises in case of fertility preservation. Okay, so the decision is by the multidisciplinary tumor board. Your first line therapy will be LNG-IUS. That is your Mirena. Okay, your second line therapy will be oral progesterone, the most commonly we use. See, the progesterone here we are using is very, very high. It is 400 medroxyprogesterone acetate, 400 to 600 milligram per day. Okay, it is very high dose. Normally, we give 10 to 30 milligram per day. And this migestrol acetate, the another option is migestrol acetate. It is 160 to 320 milligram per day. You have to give continuously without withdrawal for 6 months. And repeat endometrial biopsy after 3 months with minimum 2 consecutive negative sampling. Then after that, you send and if the endometrium shows regression, okay, then you have to send the patient to IVF, ART clinic. And once successful pregnancy and once she has delivered, and you perform total abdominal hysterectomy with bilateral salpingo-oophorectomy. And counseling is very important. You have to say this is not the standard protocol of management. And the plan of management should be executed only after discussing with multidisciplinary tumor board. So the combination of LNG-IUS with oral progesterone has better pregnancy outcome. Types of endometrial carcinoma. So you see the types of endometrial carcinoma, your type 1, which is the most common. 80% is type 1. So to imagine, just imagine a very fat, obese lady with diabetes, hypertension, PCOS, infertility, like that you imagine. So basically, the type 1 endometrial carcinoma is endometrioid histology with well differentiated. Okay. It is estrogen responsive associated with prolonged unopposed estrogen, as seen in, I told you to imagine a case, no, like in obesity, chronic anovulation, infertility, estrogen secreting tumor. So it has a course, it follows endometrial hyperplasia, and then only the patient will get endometrial carcinoma. It has a very, very good favorable prognosis with 90% of 5-year survival. And you see, it is characterized by KRAS overexpression, PTEN, PIK3CA, and microsatellite instability. So your type 1 is very common, 80% is type, and with good prognosis. See, the type 2 endometrial carcinoma, it is 10 to 20% is type 2. It is estrogen dependent. Okay, and arises from atrophic endometrium in older postmenopausal non-obese. You think old lady who's very thin and who's a smoker. You imagine this sort of picture in your mind. Okay. And tamoxifen users. So tamoxifen is this thing we give for breast cancer follow-up. No? During the period of breast cancer follow-up, we give tamoxifen. Okay. So histology. And so this type 2 endometrial carcinoma is only 10 to 20%, but it has the worst outcome. Okay, worst prognosis. And histologically, if you see, it is grade 3 endometrioid adenocarcinoma. Type 1 is grade 1 or grade 2 endometrioid adenocarcinoma. This is grade 3. Serous clear cell, mucinous squamous cell variant. Okay. An aggressive tumor with deep myometrial invasion and extrauterine spread. Basically, these are very, very aggressive tumor. The worst prognosis with overall survival rate of only 35%. So it is characterized by E-cadherin, TP53 mutation and HER2 new expression. So coming to the histological classification. So we do have a histological classification. The most common being the endometrioid adenocarcinoma. Okay, type one and type 1 is associated with well-differentiated endometrioid adenocarcinoma. Then other things are endometrioid adenocarcinoma variant with squamous differentiation, secretory variant, ciliated cell variant. And another thing is mucinous adenocarcinoma, serous adenocarcinoma. The serous is associated with CA ovary most commonly. Clear cell carcinoma, mixed cell carcinoma, undifferentiated carcinoma, neuroendocrine tumors. These are like neuroendocrine tumors like small cell, large cell, and they are poorly differentiated. So here I want to say something about the synchronous tumor. Synchronous tumor are simultaneous tumor arising from the ovary and the endometrium. But the one good point about the synchronous tumor is it has both the ovarian and endometrial tumor are having good prognosis. Okay, so yeah. Now this molecular classification is gaining popularity. So you have to know about this four basic types of molecular classification. The Cancer Genome Atlas Network has classified endometrial carcinoma into four molecular subtypes. So the first thing is pole ultra mutated tumors. The pole mutation is mutation of the exonuclease domain of DNA polymerase epsilon gene. And the good thing is it has excellent prognosis associated with low grade or low intermediate risk tumor. And the improved progression free interval also. So just remember the pole mutation are having excellent prognosis. Then the second thing you have is microsatellite instability. So the microsatellites are repeat sequences in one to several DNA bases. The repeat error during DNA replication are likely to occur in these region and they are repaired by DNA mismatch genes. Any aberration in this mechanism is called microsatellite instability. So my MSI is closely related to the hereditary tumor, Lynch 2 syndrome. And the third thing is copy number high associated with the high grade serous carcinoma and it has the worst prognosis associated with TP53 mutation. And the fourth thing is copy number low. So another very famous question from the examiner, they asked the symptoms for endometrial carcinoma. For all the undergrads, should be knowing this. The first thing is abnormal uterine bleeding in a perimenopausal women and or postmenopausal bleeding. So when you see this type of bleeding is there will be amenorrhea for 2 to 3 months followed by heavy menstrual bleeding. So this is a typical example of bleeding in anovulation in PCOS also. Another symptoms are rectal bleeding, urinary bleeding, hematuria, constipation, pain, lower extremity lymphedema, abdominal distension, ascites, hepatomegaly, jaundice, cough, hemoptysis. Whenever there is meds, you do see these kind of symptoms. History of infertility, menstrual history, age of menarche, menopause, you have to ask. Okay. So here the part of history taking also I have included. Okay. So first, you have to ask whether there is a history of infertility, menstrual history, thorough menstrual history, past history. Definitely, you have to ask about diabetes mellitus, hypertension, tamoxifen usage, HRT, clomiphene citrate. Okay, clomiphene citrate is a drug which is given for ovulation induction. Family history is mandatory. Here, you have to ask for uterine, colorectal, and genitourinary cancer, any history. Then in the general examination, you then go for examination. Height, weight, BMI, the lymph nodes, the supraclavicular nodes, the inguinal nodes, the breast examination, thyroid examination, and other systemic examination. You have to do. Per abdominal, per speculum, per vaginal, per rectal examination, you have to do to assess the uterine size, mobility, cervical involvement, parametrial involvement, lateral pelvic wall, bladder, rectal involvement. So coming to the diagnostic workup. So you see the transvaginal ultrasound. So the diagnostic workup is the same. The transvaginal ultrasound is the first line imaging modality. So to us, you have to assess the uterine size. In the TVS, what things you will see? Uterine size, endometrial thickness, endometrial interface, endomyometrial ecotexture, and adnexa. So these things you have to assess. In a postmenopausal women, if the endometrial thickness is more than 4 millimeter with heavy prolonged bleeding or intermenstrual bleeding in a perimenopausal, in a premenopausal women, the women should undergo endometrial sampling. Suppose if the woman is a menstruating woman with heavy menstrual bleeding, then the endometrial thickness cutoff will be 1.2 centimeter or 12 millimeter. But for a postmenopausal bleeding, the cutoff will be more than 4 millimeter. You have to do endometrial sampling. In the endometrial sampling, endometrial aspiration biopsy, fractional curettage, or hysteroscopy. Hysteroscopic biopsy is the gold standard. Triple A endometrial sampling we commonly do. It is a office procedure. Once endometrial carcinoma is confirmed by HPR, histopathology, then only you check for, you do MRI abdomen and pelvis. MRI is the modality of choice here, okay? Because the tissue delineation is good in MRI compared to your CT scan. So the MRI abdomen pelvis for accurate modality of assessment of size and extent of the tumor, myometrial invasion, extension to the cervix, adnexa, and extent of lymph node involvement. Your PET-CT, it is PET-CT we don't do commonly, but it is mainly used to assess the extent of nodal status and distant mets in high-risk cases. Mostly we do PET-CT in recurrence cases. Yeah, this FIGO 2009 staging. Actually, to be honest, this was very much easier, but we have this new 2023 staging. But of course, you should know the 2009 staging also. It is more simple and easy staging. So you have stage one. Stage one is confined to the uterine corpus. 1A is limited to the endometrium or invading less than half of the myometrium, and 1B, the tumor invading more than half of the myometrium. Stage 2 is cervical stromal involvement. Stage 3, we have A, B, and C. In A is tumor invading the serous or adnexa. 3B is tumor invading the vaginal or parametrial invasion. Or stage 3 is basically the lymph nodes. So the lymph nodes, 3C1 is metastasis to the pelvic lymph node, and 3C2 is mets to the para-aortic nodes. And stage 4, the tumor invading the bladder and bowel mucosa. And 4A. 4B is distant mets, including the intra-abdominal mets like liver, etc. Liver spleen involvement, and nodes like inguinal lymph. Okay, forget about this. We have the new FIGO 2023 staging. It is easy, but little more elaborate. Okay, so we'll quickly see. So the stage one is the tumor is confined to the uterine corpus and the ovary. So you can just go through this. Stage 1A, in 1A, you have 1A1, 1A2, 1A3, and you have stage 1B and 1C. So we will see what is stage 1A1. 1A1 is your non-aggressive histological type, like endometrioid, adenocarcinoma, okay, limited to the endometrial polyp or confined to the endometrium, like only the lining or limited to the polyp. And stage 1A2 is same thing, non-aggressive histological type, less than half of the myometrium. But the catch here is there is no LVSI. LVSI is lymphovascular space involvement. And stage 1A3 is low-grade endometrioid carcinoma, but it is limited to the uterus and ovary. Stage 1B is again, it is non-aggressive histological type with invasion of more than half or more than half of the myometrium. Again, here, if you see the LVSI, lymphovascular space involvement, there is no LVSI. And stage 1C is aggressive histological type, limited to the polyp or confined to the endometrium. Stage 2 is cervical stromal involvement without extrauterine or with substantial LVSI, and aggressive histological type with myometrial invasion. You have stage 2A, 2B, 2C. 2A is invasion of the cervical stroma, but here it is non-aggressive histological type. That is your grade 1, grade 2 endometrioid adenocarcinoma. In 2B, it is substantial LVSI. That is what lymphovascular space is involved, but it is non-aggressive. And 2C, it is aggressive histological with any myometrial involvement. So we saw no the serous, clear cell, those kind of aggressive tumor with any myometrial involvement. Stage 3. 3 is local or regional spread of the tumor. So we have 3A. In 3A, there is 3A1, 3A2. 3A1 is spread to the ovary or fallopian tube, except when meeting the meeting stage of 1A. 3 criteria. And 3A2 is involvement of the uterine subserosa or spread through the uterine serosa. Basically, 3A1 is ovary and fallopian tube, and 3A2 is uterine subserosa and the uterine serosa. 3B, again, mets or direct spread to the vagina and or parametria or pelvic peritoneum. Okay, so 3B1 is again simple vaginal or parametrial involvement. Mets, it can be mets or direct spread, and 3B2 is pelvic peritoneum. So this 3B2 they have added new. And 3C is mets, like a nodal involvement. And in that you have 3C1, it is metastasis to pelvic lymph nodes. In that 3C1 itself, we have 3C1 subtype 1 micromets. And 3C2 will be, sorry, this I have not put here. So 3C2 will be the para-aortic nodes. So coming to the stage 4. Stage 4 is spread to the bladder mucosa and or intestinal mucosa or distant mets. So in this you see in all the malignancy we do see this 4A and 4B. Here one new entity 4C they have added. So 4A is invasion of the bladder mucosa, intestinal or bowel mucosa. Again 4B is abdominal peritoneal metastasis beyond the pelvis. And stage 4C is distant mets like including to any extra or intra-abdominal lymph nodes above the renal vessel, lungs, liver, brain, etc. So, coming to the pathological grading, grade 1. So, after this staging, you have to do this pathological grading. Grade 1 and grade 2 are usually well differentiated, and grade 3 is poorly differentiated, having worse prognosis. So grade 1 is 5% or less of non-squamous or non-morular solid growth pattern. Grade 2 is 6 to 50% of non-squamous or non-morular solid growth pattern. And grade 3 is more than 50% of non-squamous or non-morular solid growth pattern. So here one thing you remember, nuclear grading takes precedence in case of serous clear cell and squamous carcinoma. And one more thing is this peritoneal wash cytology will not change the staging in endometrial carcinoma. So this has a role in ovarian carcinoma, ovarian malignancy, but not in endometrial carcinoma. But one thing, when the peritoneal wash is positive, it has unfavorable prognosis. Yeah, coming to the prognostic feature. So age less than 50 is good prognosis. Okay. So the older women, the type 2, which I was saying, no, it has poor prognosis. Then histological type, endometrioid adenocarcinoma, grade 1, grade 2 has good prognosis. The other things like clear serous, this carcinosarcoma are more aggressive and poor prognosis because of the LVSI involvement and deep myometrial involvement. Okay. Histological grade 3. So type and histological grade. Grade 3 are like worst because they have 5 times more likely to develop recurrence. Okay. And there is increased chance of myometrial invasion also. So myometrial invasion, if there is there, this itself increases the lymph node involvement. Suppose when there is no myometrial invasion, the lymph node involvement here is only 1%. When there is a deep myometrial invasion, you see drastically the lymph node involvement will be 25%, the pelvic and the para-aortic lymph node. The cervical stromal involvement is, it increases the risk of MEDS and recurrence. LVSI is the independent lymphovascular space. Again and again, I'll be talking about this lymphovascular space involvement. It is an independent risk factor for recurrence. And the tumor size more than 2 centimeters. Positive peritoneal cytology, this I have already told, it doesn't change the staging, but the survival, it is a marker of poor survival. The prognosis is unfavorable. The hormone receptor, as we all know, the estrogen and the progesterone receptor hormone status have good prognosis, and DNA ploidy and proliferation index. So the DNA ploidy, it is the proportion of aneuploid tumor increases with stage, depth of invasion, and lack of differentiation. And this itself is an independent prognostic factor. So this is for both undergrads and postgrads. So this is your risk grouping. So we group the patient with endometrial carcinoma into 5 categories: low risk, intermediate, high risk, and advanced. Okay, so coming to the low risk. In low risk stage, so low risk, so this I'll just read and go. So you read it from the slide. So stage 1A endometrioid, grade 1, 2, LVSI negative. So remember the low risk. Why so the management, no, the management, the adjuvant therapy depends on this risk stratification only. So, okay. So the low risk is stage 1A, well-differentiated endometrioid adenocarcinoma, grade 1, grade 2, but LBSI negative. So this comes under the low risk category. The intermediate risk is stage 1A endometrioid, grade 3, LBSI negative or focal. Stage 1A non-endometrioid, any grade with no myometrial invasion. Suppose if there is myometrial invasion, it comes to the fourth risk. What is that? The high risk group. Okay. And stage 1B, grade endometrioid, grade 1 to LVSI negative or focal. So all this comes under intermediate risk group, and high risk group is stage 1A endometrioid, any grade with the LVSI. See, LVSI, if it is involved, it directly comes under high intermediate, even though it is stage 1 endometrioid well differentiated tumor. Okay. And all your stage 2 is high intermediate. So from stage 3 to 4, without any residual disease, it can be non-endometrioid with the myometrial invasion, but the only thing is there should not be any residual disease. So this will be your high-risk group, and advanced metastatic will be stage 3 to 4A with residual disease, and your stage 4B. Nowadays, there is 4C also, stage 4C also in the new classification. So everything will be advanced metastatic stage. We'll just quickly go through the FIGO stage 1. So stage 1, we all know, okay, when the tumor is grade 1 or grade 2, well-differentiated endometrioid adenocarcinoma, the only management will be extrafacial hysterectomy with bilateral salpingo-oophorectomy. But the lymphovascular space should not be involved. That is your low-risk group. For this low risk group, you don't need to take the patient for adjuvant therapy also. Okay. And your intermediate risk group, which we were talking, is stage 1A, grade 3, stage 1A non-endometrioid. That is your aggressive tumor, histological tumor, stage 1B, grade 1, 2, and stage 1B, grade 3 endometrioid. With any LVSI, you have to do total abdominal hysterectomy, bilateral salpingo-oophorectomy with bilateral lymph node dissection, with bilateral pelvic and para-aortic lymph node dissection. So for all the cases, you will do staging laparotomy, but for a well-differentiated, that is your low-risk group, well-differentiated endometrioid, You do extrafacial hysterectomy with bilateral centrifugal. I mean, no need for lymph node dissection. So here, the lymph node, the removal of your ovary is important. It's mandatory because there is a risk of micromets. In patient less than 45 years, stage 1A, grade 1 endometrioid, ovarian conservation, that is your low risk group under age 45 years, ovarian conservation can be considered, but you have to perform this bilateral salpingectomy. So now this is important. The route can be anything. It can be open, laparoscopic or robotic. Okay. But one thing you have to keep in mind is when you're performing this minimally invasive surgeries like laparoscopy, the specimen morcellation is not possible. You have to take in endobag. The morcellation and spillage is not possible. So this holds good for the ovarian malignancy also. So the staging laparotomy, this is a very common question for undergrad. They ask what is staging laparotomy. So we'll see what is that. And before that, we'll see what is the pre-op evaluation. So confirm histological type and grade. Very important before performing the staging laparotomy, you have to confirm histological type and grade. MRI to assess the extent of the tumor and size, multidisciplinary tumor board decision, and appropriate management protocol. And you have to correct the anemia, CBC, RFT, LFT, evaluate for diabetes optimized with insulin, cardiovascular evaluation, chest X-ray, ECG, echo, control BP with antihypertensive drugs, do PT-INR, APTT, screening for serology and rule out infection. Counseling is extremely important. Explain the indication, benefits, risk, and there is no guarantee as to the outcome, but we all know the type 1 endometrial carcinoma well differentiated. That is your low risk group has good prognosis. And you have to say about here, it is very important to say about this adjuvant therapy like chemotherapy or radiation. You have to say prior itself that there might be a need of adjuvant therapy after the histopathology report and the post-operative complication. So they evaluate the risk for DVT, varicose vein, estrogen therapy, obesity, and prolonged hospital. So you have to say about say that there is a risk for deep vein thrombosis. The patient should not be immobile. So staging laparotomy. So you give antibiotic prophylaxis. It's recommended. The commonly which we give is cefazolin, 1 to 2 gram 30 minutes or 60 minutes prior to the incision. Put the patient in the supine position or in lithotomy, and incision will be midline vertical. So this is about the open in staging laparotomy. So the incision will be midline vertical. And the peritoneal, first thing is you have to take the peritoneal washing. If there is peritoneal fluid, you take the fluid and send immediately. Put it in a heparinized container and send immediately. Otherwise, if there is no peritoneal fluid, like no ascites, you can take peritoneal washing of 50 to 100 ml and collect it from the pouch of tablets. So explore the abdominal cavity from peritoneum of right anterior. So you have to start from the right side. You have to start with the peritoneum of the right abdominal wall, then right paracolic gutter, then right kidney, then gallbladder, right liver, hemidiaphragm, then come to the stomach, spleen, left anterior abdominal wall, left paracolic gutter, left kidney. Everywhere you just explore, and all the suspicious areas you have to take the biopsy. So systematically, you will be inspecting the small bowel. Once bowel are outside, then you have to palpate for the lymph node, continue lymph node palpation to bilateral pelvic lymph nodes. Okay. Finally, see all the suspicious areas you have to take biopsy. For the undersurface of the diaphragm, you can take the diaphragmatic scrapings also. So here, then peritoneum, you have to take biopsy for the peritoneal implants, and then you have to assess the size of the uterus, mobility, ovaries, tubes. Then follow with total abdominal hysterectomy, bilateral salpingotomy after clamping both the conua to prevent spillage. This we all know. It is like hysterectomy part only. Okay. But here, one important thing is while closing the vault, apply clamps across like this. You have to put like this across the vagina, distal to the cervix, and remove the specimen. So the vault should be kept close to prevent spillage into the vault. Then you just proceed with the pelvic and para-aortic lymph node dissection. So one thing is the para-aortic node dissection is up to the left renal vein. This way will ask the extent where you will take the lymph node for para-aortic nodes. You have to perform omentectomy in case of these tumors, these histological groups of tumors like serous, mucinous, and undifferentiated. So the post-op care, mostly there can be lymphocyte formation because we are removing a lot of nodes, right? So this can be prevented by using vascular clips at distal and proximal end during the lymph node dissection. And you have to put a IP drain, intraperitoneal drain with sections. DVT, there is high risk of DVT, so thromboprophylaxis is must. DVT compression stockings you have to use. Most commonly we give enoxaparin and early ambulation hydration. Antibiotics. Antibiotics, actually, we do give a repeat dose. But here, you give a repeat dose if the surgery is prolonged or the blood loss is more than 1.5 liter. Early ambulation, early feeds, shorter catheter duration, and plenty of oral fluid, and correct the electrolyte imbalance to prevent, it will promptly prevent is the potassium level you have to correct, it will prevent the post-operative release. So, lymphadenectomy in CA endometrium. Only remember, you need lymphadenectomy in all the cases except stage 1A, your low risk grade 1-2 endometrioid without any lymphovascular or myometrial invasion. Okay, in that case, lymphadenectomy is not required. Others, everywhere you have to do. Both you have to take the pelvic and the para-aortic lymph nodes in systematic fashion. That is systematic lymphadenectomy you have to do. And the adequacy is minimum 4 nodes you have to take from each area. Okay. So remember, it does not have any therapeutic value. So systematic lymphadenectomy is recommended. This is what I was saying in all the intermediate, high risk group, advanced group, everywhere you will do lymphadenectomy. But remember, once if the pelvic lymph node is involved intraoperatively, then you don't do systematic pelvic lymph node dissection. You stop there and instead you take all the grossly enlarged node. You do debulking and then you proceed with systematic para-aortic lymph node staging. Okay. So management of FIGO stage 2 EC endometrial carcinoma. Total abdominal hysterectomy with bilateral salpingo-oophorectomy and systematic lymph node staging. This is the standard treatment. That is, you have to remove the pelvic and the para-aortic nodes. So here this radical hysterectomy, because most commonly the cervix will be involved in stage 2. So cervical stromal involvement will be there. So the radical hysterectomy in stage 2 and stage 3 endometrial carcinoma have no impact on local recurrence rate, the disease-free interval, or overall survival. So it is, don't do radical hysterectomy, proceed with total abdominal hysterectomy with bilateral salpingo-oophorectomy and pelvic and para-aortic lymph node dissection. So the adjuvant treatment, this again and again I'm saying the adjuvant treatment can be radiotherapy or chemotherapy. For the low risk group, remember the stage 1A well differentiated grade 1-2 endometrioid adenocarcinoma with no LVSI. No adjuvant treatment is required. Otherwise, for all the groups who need adjuvant therapy. So in the intermediate groups, you give adjuvant brachytherapy which, to prevent vaginal recurrence. So the dose and other things I'll be saying in my subsequent slides. In the high-risk group, if there is LVSI involvement, then stage 2, EBRT, external beam radiotherapy, can be considered. Okay. So whenever there is lymphovascular space involvement, the lymph nodes the para-aortic node involvement is there. There is a higher chance of para-aortic lymph node. So definitely you have to give EBRT, external beam radiotherapy. Adjuvant EBRT and chemotherapy is recommended with substantial VSI involvement. So there can be micromets also. The chemotherapy will tackle that. Management of advanced endometrial carcinoma stage 3, stage 4. So optimal cytoreduction is recommended in patient. Okay, so when you have to do R0. R0 is optimal complete removal of all gross disease. That is called optimal cytoreduction is recommended with resectable patient with resectable disease and good performance status. So there is a ECOG performance grading. Based on that, we will classify. Okay. Then surgery should be performed in onco center after tumor board discussion. Suspicious lymph node should be resected, but systematic here, no, there is already the patient is in advanced stage, stage 3, stage 4. Here, there is no role for doing systematic lymphadenectomy. Only the grossly enlarged nodes, debulking you do. Management of unresectable tumor. Is the unresectable tumor, you directly go for radiation, radiotherapy with EBRT and intrauterine brachytherapy or vaginal brachytherapy, or neoadjuvant chemotherapy prior to surgery. Two modalities are there. But if there is any residual pelvic or para-aortic lymph node, a combination of concurrent chemoradiation, that is EBRT and chemotherapy. So the purpose of giving the adjuvant chemotherapy, it reduces the risk of distant mets. So post-treatment surveillance, following surgical treatment, patient should be reviewed every 3 to 4 months. Okay. So after the surgery, the patient, you have to follow up the case, which is very important. Every 3 to 5 months, you have to take history, pelvic examination, ultrasound if required, TBS for the first 2 years. Then thereafter, every 6 months you will do. Okay, every 6 months you will do up to 5 years according to this ACOG and this ESMO guidelines. So for the suspected recurrence abdominal, you can, if you are suspecting any recurrence, you do a abdominal or pelvic CT. Okay. If you're suspecting mets, then you can ask for PET CT. Psychosocial assurance is very important, and the optimization of diabetes, hypertension, breast examination is mandatory here. Counseling, control of obesity, smoking cessation, other things. But here one thing is they are not recommending vaginal cytology because the detection of recurrence by vaginal smear is only 1%. So nowadays vaginal cytology is no longer recommended. But other things like you have to ask for symptoms, clinical examination, parabdominal, parspiculum, parvaginal and parrectal examination you have to do, and surveillance CT. So this, if you suspect recurrence, you have to do pap smear or vaginal smear is no longer recommended. Hormone therapy, for hormone therapy, it has very good response to ER-PR positive, estrogen receptor to progesterone receptor positive tumor. It can be used for recurrent or metastatic disease. So the most common things we are using is the progesterone agent, like medroxyprogesterone acetate, megestrol acetate, tamoxifen, aromatase inhibitor, fulvestrant. So if you give tamoxifen has 20% response rate in disease that does not respond to the standard progesterone therapy. So combination of tamoxifen with progesterone can be used, but there is high risk of DVT. So coming to the fertility preservation, okay. Fertility preservation is indicated in patient with I've already talked about atypical hyperplasia or EIN and grade 1 endometrial adenocarcinoma without myometrial invasion. So one thing is you have to assess the molecular status also. If it is a pole mutation, it is good. But this copy number ITP53 mutation or MSI micro satellite instability, so it should be negative. Okay. So pole mutation are the ideal candidate. So the diagnosis should be confirmed by hysteroscopic biopsy, not by your office procedure. AAA, do a gold standard hysteroscopic biopsy and evaluation by expert ultrasound and MRI. And again, tumor board discussion should be there. And you have to counsel. This is very important. You have to counsel. This is not the standard treatment of care. Then evaluate the risk factors, other risk factors, hysteroscopic, same thing. Hysteroscopic biopsy prior to the progesterone therapy is recommended. The same dose, migestrol acetate 160 to 320 milligram or medroxy. Progesterone acetate 400 to 600 milligram is recommended. LNGIS with the progesterone has good outcome. To follow up, how to follow up? Same thing like which I've told previously. Hysteroscopic guided biopsy. You have to take a third month, 6 month. If there is no response, then you proceed with surgery. Okay. So by this time, if there is any response, if the lesion has regressed, then refer the patient to this IVF ART clinic. And once after this successive pregnancy, perform this risk reducing or perform hysterectomy with bilateral salpingo ovulet. So hysterectomy with BSO is recommended after childbearing due to high chance of recurrence. When to discontinue the treatment, the disease persists more than 6 months to 12 months. The progression of the disease or a stable disease after 6 months of treatment. So you have to, imaging should be repeated after 6 months to rule out. So before 6 months, you're doing MRI. Again, after the therapy, after the treatment, you have to again perform this MRI after 6 months to rule out myometrial invasion or extrauterine or ovular. So this is another thing examiners can ask you. Endometrial carcinoma detected after hysterectomy. So suppose they have done hysterectomy for some abnormal uterine bleeding or so, and the histopathology is showing endometrial carcinoma. Now what you will do? So first thing is the proper evaluation should be done prior itself. Endometrial sampling should be done prior itself before doing any hysterectomy. So only I have written the situation is best avoided and assess whether the ovaries are preserved. So after HPR you have to evaluate. Okay. So in the you can ask for this PET CT in case you're suspecting METs or CA125 assay. So if serum CA125 assay is elevated or PET CT reveals lymphadenopathy or evidence of METs, then you have to do again staging, again complete staging and completion surgery. Suppose if it is a very low risk, low grade, like low risk group, 1A, stage 1A, endometrioid, grade 1, grade 2, no LVSI, only observation is required. But one thing you should know, check whether the ovaries are preserved. So if the ovaries are preserved, you have to remove the ovaries laparoscopically. Yeah. And in all the high risk group, you have to do complete surgical staging. Alternatively, suppose if the patient is not giving consent for surgery, you can proceed with EBRT. Okay. So principles of radiotherapy. So I've already told no any apart from the low risk group, others everywhere you have to give this radiation. So this extended field radiotherapy will cover the entire pelvic and common iliac along with the para-aortic lymph node up to the left renal vein. That is the extent. We are removing the nodes also. EBRT for the microscopic disease. The preferably what we use is 40 to 50 grays. Brachytherapy administered 4 to 6 weeks from surgery or when the vaginal cuff is healed. Only after that you take the patient for brachytherapy. The treatment volume should include the vault and the upper 2 to 3 centimeter of the vaginal cuff. So this and all you read. The high dose rate is brachytherapy is 7 gray. You give 3 fraction, 0.5 centimeter from the surface. Okay. EBRT followed by brachytherapy means you give 6 to 7, 2 fraction, 0.5 centimeter from the vaginal mucosa. So coming to the end, the take-home points. All patients with heavy menstrual bleeding or postmenopausal bleeding, proper history taking is required. Okay, history taking and evaluation. So evaluation must include the basic transvaginal ultrasound and endometrial biopsy. These are the 2 basic first line evaluation. And if you find anything abnormal in this biopsy, HPR, like endometrial carcinoma, you have to proceed with MRI. When endometrial carcinoma is indicated, do MRI. Then pathological grading of endometrial biopsy is extremely important. Risk stratification, I've told no, the groups, the FIGO groups, high risk groups, and histological type, grade of the lesion, myometrial invasion after treatment of endometrial hyperplasia. Endometrial surveillance is very important. Okay, before that even you have to say. And primary surgery is the treatment of choice in endometrial carcinoma. Systematic lymphadenectomy is indicated in all except in the low risk group. Again and again, I was saying about this. Lymphadenectomy should include both pelvic and para-aortic nodes. Surveillance must be done to find out pelvic or distant recurrence. So all the management, let it be hyperplasia or malignancy, it is according is after only after the multidisciplinary tumor board discussion. Thank you.